in collaboration with the centre. So it focused on community-based participatory research project about how we can find solutions for community-based approaches to support each other's physical and mental health. Cool, and I'll just go through to the next slide, if I can. Yeah, so just a few house rules. So if you've got any questions or want to introduce yourself, just to please put that in the chat box. We ask that everyone keeps themselves on mute at all times, if that's okay. Just sometimes you get a bit of feedback and things like that. And then a recording will be shared with everyone after the webinar as well. Cool, and just to go through some of the agenda today. So we're going to have a bit of research and policy context. So we're joined by the wonderful Aileen Valydon from the East London Foundation Trust. So she's going to start off with a bit of policy context around sort of the mental health situation in the area at the moment. And then we'll be joined by Steve Gillard of City University, who is led on some of the research project. And he'll be joined by Calder Holmes, who is actually one of the community researchers who worked in collaboration on that. And then there'll be some examples of good practice, so sort of co-production, peer support, and we'll be joined by Layla from the Bromley by Bowes Centre, who's our social prescribing manager, and she'll talk about the centre's Community Connectors programme. Unfortunately, we're meant to be joined by Mind UK, but and unfortunately due to staff illness, they weren't able to make it today. And then we'll have a bit of sort of evaluation at the end, so how we can make this change and to community support methods and sort of looking at the future and any questions you might have. And I hope that's all good. And so now that Mind aren't coming, there might be a bit of an opportunity sort of midway to ask some questions. And if not, we're very aware that we're eating into everyone's lunchtime. So if not, then go to the toilet, grab a snack, have a drink. Cool. So without further ado, I'll stop sharing this slide and then I'll get up Aileen's and I'll hand over to her.
I was about to say good morning. Good afternoon, everybody.
Yeah.
So I'm Aileen Valydon and I'm an operational lead for the Isle of Dogs neighbourhood mental health team in Tower Hamlets, and we cover network 7 and 8. There you go. Can you all see the slides? There you go. So I do have 2 hats on. So my next role is actually I'm the community connector lead for Tower Hamlets, Elft. Now, that will have a bearing on how I actually present these slides. So can we have the next slide?
Yeah.
In true NHS style, it's always good to kind of have these wonderful links. So for everybody else, I think it's really good for you guys. If you haven't read it, have a good read. The first link is the NHS England link to Community Mental Health Framework for Adults and Older Adults. And we've largely really looked at this in terms of redesigning our community mental health services. And it's basically provided a framework on how we began to operationalize our neighborhood teams. Now, in terms of our community mental health transformation, I would urge you to watch this YouTube video that is on the next link. I appreciate you might not be able to click the links in my presentation. So Naomi's kindly said she'll put it in the chat box later on for you guys to link it up. Kind of saves time and I can actually get to the heart of the matter quite quickly. Next slide, please. So by way of introduction, we talk about practical support and I apologize if I'm just going to go straight into this. But essentially what's really important for us in mental health transformation and in providing a very different offer to our neighborhood, in Elf particularly, is that we understood right from the beginning that we weren't meeting the needs of our local population. Clearly, we had people experiencing various mental health crises and meeting a lot of barriers at between primary care and secondary care offers. So a lot of people were falling between the gaps, and largely community mental health services had a lot of barriers to people getting help. For our part, particularly in East London, we were very mindful that we needed to improve. See, the NHS were very, very good at changing things, but really what we do is change the name, but do exactly the same things. So this time around, what we said is actually, rather than just looking at names, let's look at our actual processes and how we conduct things. So for our team, for Network 7 and 8, way back before transformation, we decided to look at quality improvement, look at how we can change things. And largely that was successful between 2017 and 2020. But we encountered a lot, and I will talk about this slide in a moment. We encountered a lot of barriers ourselves because our services did not look like this, as you're seeing now. It was very linear, and there were a lot of lines that didn't quite connect. So the pandemic for us was actually amazing. What we tried to change in 3 years, we managed to change in 2 weeks. As soon as lockdown happened, it was amazing because suddenly we didn't have any choice and we had to change. And that really led to all the work, the pre-work that we've done in terms of, co-production with our people participation leads, people who with lived experiences, who were working with us in changing how we actually responded to our local population. We talked about the outcomes that were needed. We can't just, the problem what we had was we were very vague. Organizationally and within our offer of services, there was always a vagueness in what we were actually offering. So for people who were using our services, it was already a challenge because they were already either at points of crisis or about to go into crisis. And what they needed was practical help. And they needed it now. And it just didn't help when they had to go into waiting lists and basically get bounced from one service to the next. So I'm presenting to you what is effectively version 10 of our operational policy and what our neighborhood team looks like for the time being. And in it, what you would find is rather than saying you've got a community mental health team on one hand and primary care on the other and all these specialist services, by and large, within our neighborhood team, we actually have all these services trying to sync up with each other. So organizationally, I'm the operational lead and I actually have oversight across this particular system. But each system largely operates by itself on its own, and we work very, very hard in making sure that we liaise with each other. What does that mean? It means that we're trying to dissolve some of the barriers that we have between services and specifically between primary care and secondary care. It means that when somebody presents at crisis point or even on their way to a crisis point, hopefully they don't get that far, that actually there is a neighborhood team there that you can consult with and can actually post you to appropriate services at the time when you need it, not when you're at crisis point. There's going to be, I'm sure there'll be questions later on about what these services are, but largely what this means is on a day-to-day basis, we actually have daily virtual team referral meetings where all of these services can refer. If any service users within our local population are actually asking for support, there are various entry points. Those entry points can be accessed and they can then feed into these referral systems. I know some of you can be skeptical and say, oh God, Aileen, this will take years. No, it doesn't. We actually have data. So you can see your GP at 9 o'clock and at 2 o'clock, somebody's calling you back. But don't hold us to that for all the time because actually, believe it or not, we have a large population here in Tower Hamlets. But we do prioritize, and part of that prioritizing is us ensuring that we actually understand who is in our local neighborhood, who can provide those services. So in typical NHS style, this is a wonderful diagram, and I'm sure you're all thinking, God, this is so neat and tidy. So can I please have the next slide?
Of course, yeah.
This is what our reality looks like. For those of you that don't know, this is Maha Beach. It's one of the most dangerous beaches because it's on a flight path. So that wonderful diagram that you just saw earlier on, in our day-to-day lives, largely this is the experience currently. Now, please bear in mind that the NHS has been here forever and a day. And we've just started this work in 2020. So we're relatively young. But what I wanted to illustrate here is when we start thinking about culture, it is going to be an absolute mess. Everybody has a particular purpose. Oh, no, that's the last slide, Paul. Not yet. So this particular slide is our current reality. And the reality is everybody has a purpose. We need to land that plane safely. But other people, particularly those inside the plane, all they want is to land safely. So people who want services, all they want is to get that. They don't care really how to go about it, how that's going to happen. They just need to get it. And if you look at the rest of the picture, other people have other purposes there. Some are just there to swim, some are there to take pictures. I just wanted to illustrate that in our day-to-day lives, that diagram, every single part of the service has a particular purpose. And what we're really trying to do is look at the overall picture. What are we actually trying to offer our local population? What is practical? How can we do that? Next slide, please. So this is Waterloo Station. So it's not quite the beach. And I made sure I got an artist impression so we don't get identifiable people. But this is what we're currently trying to aspire to. Now, what does this mean? Essentially, that massive clock that dominates. Whether we like it or not, we need to be efficient. And actually, whether we like it or not, we need to understand the purpose for our service and how our local population need to be signposted. It's not always neat and tidy, but actually they need to understand how to get from A to B. And as an organization and as our local neighborhood team, we need to be very, very mindful of what we need to put in place to make sure that people are able to access services and appropriate services and actually get from A to B in a safe manner as possible. And you kind of think, well, that sounds quite easy. It's not. That's why I like to present these very visual kind of pictures, because it's helped us really understand the process of change that we're trying to do in our neighborhood teams and how we understand and conceptualize what the NHS wants us to do, what the organization expects us to do, and what it really looks like on the floor when you're working with our partners. Next slide, please. So this is our current learning in terms of our neighborhood teams. Number one, and if you can remember those three images, what we have learned is actually we're not very good at being transparent. And I'm sure my research colleagues will the research that my colleagues will be presenting later on will talk about this. People are almost always disappointed because they never feel that we are as honest as we can be about our offer and our outcomes. So it was really important for us to be very, very clear right from the off about what our offer was, what we can do, what we can't do, and be able to communicate. We're not very good at communicating the NHS. So rather than just say to people, I'm sorry, we're not able to help you with this, but we can help you with that. We'd rather say, how about we put you on a waiting list? And then at the end of 2 years, we actually say, oh, somebody's gone off sick, or actually that service is no longer available. And by then, people might have actually felt much better or gotten worse. Being able to actually be very clear about our reality versus expectation from our local population and between our services. There's been a lot, I think people kind of lump us together and say, oh, we're NHS, we should know each other's services. Unfortunately, we don't. We need to always be reaching out to each other. And we have been doing that. And that poses its own challenges because we all have a very different way of expressing and articulating our offers. And our local population have a particular way of understanding what these offers are. So it's always important that we're communicating and we're transparent about what the reality is, because sometimes we can't always give what people want. And there are always challenges to actually negotiating how and what you can give with what people need. And last but not the least, I mean, we talk a lot about policy, context, organizations, but what we don't pay particular attention to is this defining our relationship. We always talk about collaboration and partnership. And I'm always very mindful, particularly our team, in actually defining what that means. That's why I put this in. I mean, our team is saying, Aileen, don't forget, whatever happens, you must put that in. Because if you have a very, very clear sense of how you're working with individuals, whether that be partner agencies or internal and external to ELFT, whether that's your service users or their carers, it's really important that you define your relationship. Is this a partnership? Is this a collaboration? What is the purpose of our relationship? What is the purpose of you being here? What is the desired outcome and what is your essential outcome? Right from the off, because then you're able to then very much determine those practical solutions to what people are giving you. And if I may end it by saying that when we think about mental health, we always think about mental health in context of mental ill health, which is really not helpful. Mental health is really about thinking how somebody's strengths is playing out so that they have a quality of life defined by them, and also in discussion with you in whatever context that you're partnering or collaborating in their care, if that makes sense. So for us, what we've done in terms of our neighborhood is we've created new roles. I'm shortly finishing. So rather than just having traditional roles in community mental health teams, which we've always had, and we continuously need them, such as your medics, your nurses, your doctors, your social workers, we've created new roles. So in our new neighborhood teams, I beg your pardon, we have community connectors, we have employment specialists, we have peer support workers. We are beginning to identify and have identified specific pathways that really do not always lead to crisis pathways or pathways towards inpatient care. I'd like to conclude by saying that our local population actually want to remain healthy in the community, but healthy according to them and actually defined by them, not defined by health or mental ill health. It poses a continuous challenge to all services. So as a way forward, we are continuously improving that understanding by making sure that we are very much attending not only meetings to do with partners, but actually making sure that we are there with our local population, meeting with local people, understanding what the needs of the local population are, and working side by side with our local authority to understand really what the presenting and emerging issues are. And that's my presentation.
Thank you, Aileen. That was absolutely brilliant. Yeah. And we're just going to open up if anyone's got any questions for Aileen. Just sort of give like a 2-3 minute session. I see Natalie, you've got your hand up, so feel free to unmute.
Oh, sorry, I was just clapping.
Yeah, okay. No,
it was a great.
Yeah.
Sorry.
That's all right, no problem. Yeah, if anyone's got anything, feel free to unmute or put it in the chat, and if not, we'll move on swiftly.
Just, it's me, Elahed. Wanted to know, this is in other boroughs or the other kind of the different boroughs. Do we have the same similar situation happening at the moment with the mental health services or only on your borough?
Hello. So Elft has 5 local authorities underneath it. So it's City and Hackney, Newham, Tower Hamlets in London, and then we've got Luton and Beds. And yes, neighbourhood teams are live in all of our boroughs. We have variations. I need to explain that. There's a caveat to that, because we are very lucky in Tower Hamlets because our neighbourhood mental health teams are integrated teams. By that I mean, for example, myself, I'm the operational lead, but I manage both local authority employees and Elft employees. We don't necessarily have the same makeup across all the neighbourhood teams. It makes it easier when we're looking at transparency, decision-making, and our offers, because actually it's just me talking to myself in front of a mirror and arguing with myself.
Brilliant. Yeah. I don't know if is there any more questions? If not, we'll move on to Steve and Kelda. No, it doesn't look like it. Thank you, Aileen. That was, as I said, that was absolutely brilliant and really great. So thank you. And Steve, I think are you sharing your screens for this? We'll move on.
Yes, I am.
Cool.
A second. Okay, can everyone see?
Yeah.
Okay. My name's Steve. I'm a mental health researcher based at the Centre for Mental Health Research at City, University of London. And I'm presenting today with Kelda Holmes from the Bromley by Bow Insights team. Kelda, do you want to say hi?
Yeah, I think, oh yes, I am off mute. Yeah, hello everybody.
Yeah. Okay, I'm gonna start. I'll do the first couple of slides, then hand over to Kelda for the main part of the presentation. So we're talking about a project we did jointly, a community-based participatory research project looking at community, culture, and peer support in mental health services. So really exploring understandings of mental health and of mental health support, in this case, specifically with women from South Asian communities living in East London. Just before we get into that, what do we mean by peer support? We probably all know what peer support is. It's just what we do when we recognize kind of shared experiences of difficult things, challenges in our lives, and we connect about that and we offer each other emotional or practical support. In the case of this project, we're specifically talking about shared experiences of mental distress or mental health services, using mental health services and the support we might offer each other then. And the important thing about peer support that people often say is it's very much a two-way reciprocal relationship. It works in both directions. We support each other and we learn from each other. So in that sense, it's different perhaps from a kind of clinician-patient relationship where one person is the expert helping the other. Just a bit of context for the project. Where do we start from? Most of the research, mental health research we do at City is based in the NHS. Not all, but most of it. And we recently finished a very large project looking at peer support for discharge. So discharge from inpatient mental health care into the community. So that was a national project. Hundreds of people were involved in it. One of the things we found that we didn't expect was that Black people using mental health services benefited much more from the peer support they were offered than other people. So white people were kind of in the middle. Asian people from Asian communities actually didn't benefit so much from peer support. And we didn't expect this finding, and actually we didn't collect the information we needed to make sense of it. So what was going on here? Was it something about the way the peer support was offered, or was it something about how people look for help, or who uses mental health services? We didn't have that information. What we decided to do is, instead of kind of looking inward at what's going on in the mental health trust, that we needed to look outwards into the community, that the insight, the knowledge around this lies within communities, that understanding of what support people want for their mental health and what peer support might look like, that knowledge is already out there, and we needed to work with our local communities to make sense of that. So that's when we approached the Bromley by Bow Insights team, and really kind of handed that question over to the team, and the team devised this wonderful interview-based project. So they collected the stories of 8 people about their mental health and support for mental health, women from South Asian communities. And at that point, I'll hand over to Kelda to tell you about what the study found.
Just to say that as a community researcher, I'm coming in at the end of this because I looked at the interviews once they'd been conducted, and my colleagues who aren't here today did the actual interviews, but I was familiar with the content, and just that essentially, to start off with, there was limited recognition of the term peer support in the interviews. And so there were 4 reliable sources of support for mental health that were found. That was self-reliance, faith in God, support from close family and friends, particularly emotional and practical support, and support from mental health professionals. But these sources didn't always meet participants' needs, and many talked about feeling alone and isolated. Next slide, please.
That's Steve. Next slide, please, Steve.
I can carry on talking. Thank you. However, people did talk about positive experiences which contained elements of peer support, both in group and in one-to-one settings. And this ranged from carers groups to art classes to casual friendships, and support from imams, children's teachers and pharmacists. And there's some quotes coming up in the next slide, basically to say that there were many benefits of the wider source of support which participants connected to improved mental health. So it improved their confidence and self-esteem, validation of shared experiences, a wider support network, positive emotions and self-expressions, and power to change the system. And now, can we go on to have a look at this one? So yeah, just about feeling better within themselves from having some chance to connect with somebody else. But then if we just go on to the next slide, which is about quality of peer support. There were 4 qualities of peer support which stood out: structures of sessions, fairness and flexibility, approach, character and communication, content, learning and perspective taking, and presence, building relationships in a connected space. And then finally, just want to, I know it's giving you a lot of information, but this next thing that I'm going to give you is just a vignette of one person's example of what peer support meant to them. So I'll just, this is slide 9. Oh, there we are. So for Asia, peer support means when they really listen to you and don't make judgments and let you think about the solutions yourself. And if I'm struggling, give me a few solutions to work on. So also to understand my cultural perspective and how my culture plays a major part in my health and well-being, and that's important to my identity. So a lot of it about not being judged and being allowed to be who you are, and not immediately just say, yes, thank you for that, I'll work with your solution, but actually finding a middle ground. But Asia experienced stigma from her friends and family and is insistent on the importance of breaking taboo around mental illness. And over time, Asia has developed a new network of friends with shared experiences, and mentions the role of gentle support and challenge, such as a disabled friend challenging her about being open about her diagnosis. And she's received support from a counsellor and valued her flexibility. So she says, I could contact her when I needed her, but stay away from her when I didn't. And she later became active in inclusion groups, building self-esteem and confidence, where she held a leadership and facilitative role. Aisha is very clear about the careful work needed for success in these groups, around clear ground rules and a principle of inclusion, and the role that they can have in empowering group members. She says that a lot of us were made to feel the same thing. You can see a pattern there, and we realise that it's not you because we do internalise. But because of lack of funding, the group's no longer operational in the same way, and she's concerned that the progress is going backwards on this vital work. And back to you, Steve.
Thank you, Hilda. Okay, so just a couple slides to finish off. There we go. So one of the things we ask people is if peer support kind of can fill this gap in the sorts of support people access, what would it look like? What would ideal peer support would be? And what, for this group of people, might culturally specific peer support look like? And one of the things that there was agreement with is that actually support within groups of mixed culture is helpful for people. It's good to share different perspectives on mental health and on life in general. But for that to work, there is actually a need to build a kind of sense of being comfortable, a sense of trust in that group, so that people feel welcome and able to share their personal experiences. And there were some suggestions for what this might look like. So some people said it might be helpful to have a Bengali or Sylheti speaker present for those who there's some language barrier, or who might find it new to talk about their mental health outside of a religious or cultural context. Being introduced to the group through someone they trusted, so an advocate or something like that. And that sometimes same gender or same language groups might be necessary for some people to feel comfortable and experience that trust. People emphasize the need for that peer support space to be separate from their everyday lives. Through obvious things like agreeing group confidentiality, but for some people, being out of a cultural context and feelings of taboo around mental health was important. Thirdly, wider mental health awareness building was really important for people. People felt that the knowledge about mental health could be improved generally. That was valuable for people, sharing information about mental health, having other people come and talk about mental health. And that actually would support developing other sources of support across the community, kind of better understanding and tools for self-care, not just peer support. It was also felt to be important that mental health professionals kind of improve their understanding of how culture, identity and so on impact with mental health. And that kind of mental health awareness building, peer support, actually works both ways. There's an opportunity there to raise awareness among mental health professionals around things like celebrations, around cultural roots and practices and things like that. And also lastly, practical ways to make those spaces accessible were really important. And that included things like disabled access, as well as accommodation around people with English as a second language and so on. And if you make that space as acceptable as possible, it's a richer experience for everyone. So what might that space look like? So again, the importance of mental health awareness and education, including community languages, building on what's already there that's strong. So there are lots of community grassroots organizations, informal activity groups out there. There are lots of resources already there in the community, lots of knowledge and insight. So building on that, making sure things are funded where they're working and so on is important. And then around developing dedicated peer support programs, the importance of those being integrated into the community, that those solutions being driven by community groups. Not all the answers around our mental health come from the Mental Health Trust, and through the programme that Aileen was talking about, the Trust is kind of acknowledging that and working much more closely in partnership with community organisations now, so that support reflects people's experience of their mental health in community, that there's culturally specific support. And I think there we should probably hand over to you for any questions.
Yeah, brilliant. Thank you, Steve. Yeah, I mean, I actually had a question myself, which was sort of before going into the research and what you found after. What was sort of like the biggest surprising things that you found in terms of like how people felt and their, I guess, feelings around sort of like these community approaches? Was there anything that surprised you?
I could have a go first, and then Kelda might want to add.
Kelda as well, yeah.
Yeah, one of the things that surprised me but was really powerful was that idea of the gap there. So people, Kelda talked about different supports within the family and within the religious community and so on, and how that was really important, really powerful for people. But people also lacked a space to talk about their mental health in a different way. And yes, there was professional mental health services, but people spoke about going to those when they were desperate and in a crisis. So there was that gap in between friends and family and community and the mental health team, and that peer support is potentially plays a role in filling that gap before things get too bad. Somebody talked about boiling over and being about to explode. Actually, what happens at that point before you get desperate to prevent that, and that came across really strongly in research.
Yeah, and Kelda, I don't know if you've got anything to add. Or...
I mean, it was from a conversation a long time ago, but that within the community, that the pressure to rely on the community and not say there's a failing in that, and that, you know, that you actually are struggling and need something more, without that being as something that's caused by yourself. It's not your fault, kind of thing, and that then is such a tricky conversation to be had, that you then don't address it because it's nowhere safe to address it.
Yeah, no, I can see how difficult that is for a lot of people. Yeah, I can see Aileen, you've got your hand up. Oh, if you want to unmute your sister. Yeah,
I just thought this, I mean, thank you, really. I'm going to feed this research findings back to the team. I certainly think that in terms of how we deliver care and culture, there is a shift, but it's still a long way to go. When you look at the local community, professionals have a particular view of it, and really until we're actually part of that community. So this is where our community connectors come in. And I know that, you know, we've partnered with Bromley by Bow and Women's Inclusive, Kofi Afrique Mind. it's been an amazing experience and very eye-opening, because there are a variety of understanding around mental health. It's not, I mean, it's a four-dimensional kind of understanding that we won't be able to tackle if we're actually not in the community to have that discussion with that person at the heart of it. And I just wanted to acknowledge that, and that is a real challenge. And particularly for large organizations, you know, the view that we hold around confidentiality and, you know, professional kind of practices and breaches to data, it calls into question, you question a lot of that rigidity, because ultimately when somebody requires help, all these are barriers. They're actually not there to support. So we're having to rethink quite a lot of things. I mean, one of the practitioners here always talks about it as mental gymnastics, mental and emotional gymnastics for everybody. But I think we really, you know, it's something that it's a daily challenge that we have to constantly and consistently talk about and really make sure we action. So talking is not enough, but thank you.
Brilliant. Yeah. Cool. I'll just open, I'll see if there's one more question, just looking at the time. I don't know if anyone, I can't see any hands up, but if anyone wants to put anything in the chat or unmute themselves, feel free. If not, we'll move on. Cool. Yeah, well, I can't see anything come through. Well, thank you, Calder and Steve. That was absolutely brilliant. And we'll move on to Jacqueline, Sin and Naomi, who are going to talk next. Thank you. Let's get these up.
Excellent, thank you.
I'll hand over to you both.
Thank you. My name is Jacqueline Sin, and I'm going to share this presentation together with Naomi. But you can see here, our project name is called Works for Your Health, and we have a bigger team. Actually, Calder's here today, and then we also have a couple more community researchers helping us along the way. We have Satana and Fatima, and then we actually also got 2 GPs, and we have Isaac as well as Samuels as a lived experience expert. And you will see along the slides that we actually have a lot of other people who have lived experience helping and joining us along the way. So this project is actually, can I have the next slide, please? Funded by a very small grant from the Health Innovation Education Fund that was from City University. And we intentionally put most of this fund to our partner, which is Bromley by Bow Center, the Community Insight team. Because as you will see a bit earlier, we originally have a very boring title of the project called Improving Physical Health of Individuals Affected by a Mental Illness Through Co-Produced Health Resources. And the design of it and the funding is very much for a knowledge exchange project. And the design is very much a health research project. But through our collaboration with Bromley by Bow and the community researcher, we set out to make it a much more engaging project. So we have this flyers, I think is sum up. It's a research project, so we still need to get research ethics approval, which we did apply through City University. And we set out to interview 3 types of participants. The first type is people who have lived experience of a mental illness, who lived in the community, and who have experience of kind of coping with both the mental health challenges and the physical health challenges. We also recruit carers or friends and family members who support a loved one who are affected by those problems. And we're also looking for people who work in the community setting, who are supporting people on a professional and paid basis. So that will include essentially people working in primary care like GP, nurses, social prescribers, community workers, support workers. And that's what we set out to do. Next slide, please. So the project have two phases. So the first phase is for us to get information and data from the three types of participants I mentioned about what are the needs, what are the experiences of managing both physical and mental health issues. And at the end, we recruited five focus group people, total 35 participants. That was, I think, about 20 people who have lived experiences of both mental health and physical health problems. And then we have about over 10 people who are working in the community, supporting people with professional, on a professional basis, and some family unpaid carers. And actually the division of the three types I was slightly hesitating with, because at the end we have people who come with double identities. So we have a lot of people working with social prescriber or community support workers, but actually they themselves have lived experience of the problems, and actually give them an extra commitment to use their own experience to help others who go through the problems at hand. So we run the focus group using both online medium as well as face-to-face. And actually it turned out we run the focus group, was it last year? I think last year. So when the lockdown was actually finishing. But still, I think after the pandemic, people kind of like really quite enjoy the online remote participation. So we found that it's even more popular than the face-to-face. What we find from the groups was that people were really quite concerned about their health and medical side effects, medication side effects. People talk quite really passionately about how much the side effects made them put on quite a lot of weight, and then they got discriminated and shamed for the weight and the problems they have, and also make it quite difficult for people to feel energized to exercise because it can actually be quite sedating. And people were talking about actually getting help for the physical and mental health, take a lot of interactions between the health systems, actually a bit what Aileen was talking about. So you go to your GP to talk about you're putting on weight, or you want some help with your blood pressure, etc. And then the GP will send you back to your psychiatrist and say they can't do that because that involves their medication that is for the psychosis or for the depression. And then actually even in the wider community, people may be wanting to join a park walk group. And then like as soon as the organization knows that they are also using mental health services, they will be asking for referrals, or actually showing a bit of concerns that make it quite difficult even when people really wanting to do something about their physical health. And well, in both primary care and in specialist mental health services, whenever there is a health system, there's always a power imbalance. So that the doctors and the nurses and the profession assume that they know better, and people can find it quite patronizing, being told that, you know, eat carefully, do this and do that. And also find that sometimes the advice is lacking cultural considerations. Like, for example, certain diet being advised are not really particularly suiting certain people from certain backgrounds, and lacking consideration of, for example, Ramadan or certain cultural practice. And all this together, it just shows that they're lacking some holistic considerations. Next, please. And I hand over to Naomi for the next stage.
Thanks, Jacqueline. So that was our discovery phase, where we were really trying to find out what particular resource positioning we could take that would be really useful and practical. And the next phase of the work was the co-production phase. After we sort of found out these themes that the participants wanted to focus on, we went into the co-production of actually, let's make these resources, these health resources together. So we're going to have a sneak preview of these resources, which we'll hope to share with you shortly. But I'll just talk you through a little bit of the process of how we got to that point as well. So we started off with 2 workshops building on the focus groups and inviting back the focus group participants to develop the content itself. And then and really sort of drilling down, if we've got with the themes that we had, what exactly would be useful for people to have read when they were first diagnosed, or to remind themselves of now. What tips do they have for other people? So that was our first sort of focus. Then we went back to that advisory group, which was the list of people on the first slide, to make some design and editing decisions. And we invited people from the focus group to join us with those, to make those decisions too. Now we sent it to a designer to make some of those changes, and we've got our first draft back of 2 resources, and we trialed them in some focus groups and some of existing groups that meet within our within our local area. So that's all the things that we've done to date. We're in the stage now of proofreading, meeting for final approval, and then sharing the resources. So I'm really looking forward to being able to send this out to everybody on this call, and also disseminating it more widely. The key sort of things that we really focused on, that we were the messages from our group as we went through the stage, was we wanted it to have a range of different formats, and we wanted it to be, we wanted the resources to be resources that could be used in relationships and in day-to-day settings. So with your peers, with support workers, on your own, in your relationship with your GP. Secondly, it was really emphasised it needed to be visual, fun, engaging, and high quality. These were important to sort of really make it feel as a high quality resource. We had some information on the pre-existing resources that we were trying to include, and basically signpost people to what's out there already. And then we had 2 main focuses. One is supporting your own self-care and your goal setting for yourself. That was the first resource that we developed, and you'll see we've got quite a few different sort of elements of that. And then secondly, sort of tips for people to take back some of that power and be in charge of their own health appointments. And that's a resource that Jacqueline will talk through afterwards as well. So if we could have the next slide, please. Then this is a sort of a sneak preview of the resource. The first resource was called Health Forward, a pack for physical health. This is our sort of main basic sort of introduction page, where we introduce some of the what's in the pack, and you can see the people who've taken part as well. So we wanted to emphasize that relationship between mental health and physical health. Layla's just joining us as well for our next talk. You're a perfect time. And if we could have the next slide, please. So the first we had two activities within the pack. This one is our visualization activity. This actually went through a lot of iterations. A lot of the feedback we got was simplifying, making the instructions really clear, and also sort of making this, the idea for this began when somebody described that their creation that had helped them focus through a difficult mental health challenge. They've created a tunnel, and they put lots and lots of inspirational words and phrases around it. And the focus groups felt that this is like having visual images and sort of things to hold on to were really important, especially when a lot of the imagery and ideas around physical health was a very insurmountable, intractable, difficult problem. And so this is this first activity is a really useful way to start reframing that context. And actually, a lot of what has come up in the pack is about ways that people can sort of hold on to take control, to feel like they're taking control of their physical health. Could I have the next slide, please? So these are some groups of tips that a lot of the group wanted to share with other people around that topic, sort of supporting physical health. What can you do? Where do you start? How do you start thinking about it? So there are 5 themes. We've got 5 A5 cards that sort of set out some of the advice and wisdom that has been generated from people's experience. And then on the next slide, I think we've got another activity, which is a sort of a tips and tricks generator. We've got this activity, and the next one is a set of ideas cards that people have had lots of little ideas that work for them, and said sometimes actually balancing the spontaneity and flexibility with kind of routine and planning stuff in. Physical health can feel very serious, like you can and so this was an attempt to bring back a little bit of sort of just spontaneity. So using these cards in that activity to just try and sort of be a bit playful with the whole topic, and just give somebody like a little idea, something that they might be able to do for their day. So I think those are the different elements of the resources about sort of self-care and your own relationship with physical health, and all of these sort of resources were designed to be done with somebody or on your own.
Okay, actually one more resources. Can I have next slides, please? So I mentioned in the beginning, we actually really lucky to have 2 GPs who's very, very open-minded and working with the groups. And it's pretty no mean feat that actually when they come to the groups with the co-design that Naomi talked about, sometimes we can have like 20 people with lived experiences, but actually we have very, very productive discussion. So another resource we come up with is a kind of like a set of playing cards, as you can see here. Is particularly helping people to plan, manage, and really take control of the GP appointments. So together came from the GPs and our participants and the co-design partners. So it helped participants, people with lived experience, to think about well in advance that actually when I should ask for a GP appointment, and let them know that actually it's really within their rights to ask for GP appointments. And then it was very helpful as well for the GP to tell us, like, GP are trained to offer 10 minutes appointment. Quite often they would like a longer time because they actually see a lot of people within a day. And it's perfectly fine to ask for double appointment. So it's like 20 minutes, and also ask for more than 1 appointment. It sometimes happens. It's really quite useful to know a bit of that sort of system, and ask the receptionist to book extra time, or saying that I want to bring someone with me, perfectly fine. And then also help someone to think about before you go, if you get very nervous, or sometimes you feel a bit like the imbalance of power, you can actually get prepared and write down what you want to talk about your GP. Make sure that those important concerns of yourself are not being missed out. Can I have the next slide, please? And the cards actually go on to cover what actually happened during the GP session, so people can get prepared. So we come up with phrases that people can talk about their concerns. They can actually set out that I need time, and actually these are my list, and I want to bring someone with me. I want this to be looked at, and I need some tests, or other people told me that I'm entitled for some blood tests, etc. But also to have a dialogue with the GP to explain that actually there's quite a lot of long-term health conditions. For example, blood pressure, losing weight is not necessarily best treated with medication, or actually need something to go together with the medication, like eat healthily. That's definitely needed, even though you're on blood pressure tablets, or having a walk, doing exercise like the goal setting we talk about. So it's also that some mutual understanding is necessary, so that people just don't think that my GP didn't give me any medication, so they're not helping me. But just to know that whole lots of other things, healthy living, healthy lifestyle, things that people can do and take control of themselves. Next one, please. Okay, should I start the first half and then Naomi can finish? So what we think we learned is we actually find it really quite refreshing, the approach we've taken. As I say, as it set out, we intentionally leave it to Bromley by Bow community researchers to take charge. And we believe that it does change the fact that the study was really well recruited. We got loads of people sign up. We didn't really have any problem. If anything, we may struggle with stopping people like sign up, and then we can move on to the next stage. But having said that, I think also it would be really necessary to have a team of people, as we have, who are really lucky, who are really quite open-minded, and people come together and really seek out to understand each other's perspective, each other's experiences, and open to, you know, a really new approach. So we come up with resources that is like not really the usual, what is your normal blood pressure, what is your normal weight, etc. It's something much more useful and pragmatic and practical. And also I think we learned that actually is really important. If we want things to be helpful, we need to break down big topic like managing physical health, losing weight. It's not easy for anyone actually. Naomi?
And then the next steps, so we're in the process of getting ready for dissemination of the resources and aiming for them to be in settings that where they're going to be used. We'll be hopefully planning an event in May, but we'll also be sharing printed and online resources. There's also a possibility that's being explored at the moment for some GP training along the same lines, and then the evaluation of whether people actually use the resources and find them useful and engaging and relevant for them. So that's our next three sort of big steps for the project itself. We've got some contact details at the bottom if you're interested in sort of keeping in touch, and we'll aim to send all of the resources out to this mailing list as well. Alongside, we have a few peer support resources explaining peer support and breaking that down with some local peer support links. So we'll share that at the end of at the end of this as well. So thank you very much. I think that's it from us, and if anybody has any questions.
Yeah, brilliant. Yeah, thank you. Yeah, thank you, Jacqueline, and thank you, Naomi. That was fantastic. And I could see a few hands up. So I'll start with Natalie Robertson.
Sorry, trying to find the buttons to unmute myself. Thank you for a wonderful presentation. That was fantastic. My one question was what were the questions that you sort of posed at the focus group, and were those questions sort of co-produced? Do you know how so then you could make the appropriate changes to the resources that you were doing? Does that make any sense? Sorry, Naomi or Jacqueline.
Oh, that makes perfect sense. Shall I have a go and then Jacqueline have a go? Because it was an iterative process, wasn't it? So we had a few layers. We had the advisory group, which was the list of people at the beginning, including the community researchers, and so that was the place where the topic guides of the focus group questions started, and we took them to. So we were all involved in creating the questions that we wanted to ask, and then after the focus group, when it was clear, like people expressed that they were interested in developing these further and being involved more, we brought people back to work on the content together based on the themes from the focus group, which had been quite broad. I don't know if there's anything you want to add, Jacqueline.
No, exactly. As you say, we put a lot of attention into, as you say, Natalie, you imagine designing even the flyer. Originally, we have one that have a needle on it, And then like the lived experience advisory panel feedback was like, no, people with mental health issues sometimes could have false medication experience. So make it really much more engaging. With the information sheet about the study was like really reworded and helped by Isaac reading and suggesting how to put things that is easy to understand, not putting people off and not scary. And the same with the focus group with topic guide as Naomi. And actually, I remember Kelda and all of us were practicing, make sure we run the group smoothly, and then we also make sure that it's not outnumbered. I joined running a couple of groups, but also make sure like GP and myself, I'm a mental health nurse, don't outnumber the focus group. So yeah, we think about all this.
Aileen, I did see you had your hand up. I don't know if you still got something.
I was clapping.
Okay, clapping, another one. I thought the hand was up. My mistake.
Thank you.
Cool. Yeah, if anyone's got anything else, I'll leave it open for a second. And if not, I'll hand over to our very brilliant social prescribing manager, Layla, in a second. Cool. Yeah, I can't see anything.
No pressure, Paul. Thanks.
Yeah.
I'm really going to disappoint people now after you've said that.
Oh, I've got to be honest.
Hi everyone, my name's Layla. I manage the social prescribing service at the Bromley by Bow Centre, and I was asked to speak quite briefly about our Community Connector programme. I know that Aileen was speaking before me and I wasn't around, but I'm sure she's mentioned something around ELF's mental health transformation. You did, okay. So I'm here to just talk a bit about our Community Connector programme, and particularly the role of the Community Connector within mental health transformation in ELFT. And the centre was lucky enough to receive funding from ELFT a few months into the pandemic for the recruitment of 2 community connectors. And this was also, I think it's really important to mention that ELFT had specifically wanted voluntary sector organisations to apply for the funding so that we were able to deliver sort of community mental health support to the local community. And so the funding was awarded to 4 brilliant voluntary sector organisations in Tower Hamlets, and we were one of them. And so we recruited 2 mental health community connectors that would support the local patients, so local community, to who had serious mental health issues. And the community connectors in Bromley by Bow sit within the social prescribing team. And so it was really important to us that the approach that we would, or the framework that we would use with our community connectors was to use this social prescribing approach. So we developed a model of support for people that recognise the complexities of the social determinants over and above diagnosis. And supported people through a sort of blended team structure. So what's really interesting about the community connector role that excited me was that, unlike sort of social prescribers who are primarily based in primary care, the community connectors were employed by the voluntary sector, so in the community, were embedded within the neighbourhood mental health teams, so they were in secondary care, working with, you know, nurses and OTs and psychiatrists and attending blended team meetings, but also working closely with primary care and working across different GP practices. So they sort of straddled the 3, which is really, really exciting. And the programme is grounded in a population health approach to serious mental health issues, with an ambitious support vision to support more patients closer to home. And reduce the stigma and fragmentation in existing services. So it was really important for us that whilst the community connectors would work across these 3 different areas, we understood the needs of the local community and the importance of actually delivering that model of support in the community. So a lot of the community connectors one-to-ones, so they deliver one-to-one support to clients coming from the neighbourhood mental health teams, primary care, and within the community directly. We purposely have the community connectors have their clinic time within the community, so that clients feel able to open up, to be in a familiar environment, because what we really want is we want to create safe and trusting sort of environments so that people can start to talk about some of these issues and challenges that they're facing in their lives. And we felt that having it in a community setting, it was a lot more easier to get people to trust, because they're familiar with the setting. They come into the centre and they use the coffee shop and they use our other services. So it was a lot more easier for us to kind of get that kind of level of engagement. The ethos of the Community Connector programme is really recovery focused. So we're trying to move away from the traditional referral model, and this was really important to ELFT when they sort of gave us the funding and transformation. It's moving away from referrals and, you know, limiting people to maybe 2 sessions or 3 sessions, and actually it's a lot more the sort of there's a blur in the boundaries between primary care and secondary care. So what we're trying to do is encourage the community connectors to discuss client cases directly with the neighbourhood mental health teams. So, and Aileen nodding her head because she knows a lot about this because she's based in NMHT, but it's really about how can we start talking about clients and patients rather than just filling out a form and, you know, sending that over to a community connector, but actually inviting the community connectors to be a part of those really, really important discussions around that patient care. And what's really great is that the community connectors can advocate and give a voice to the social determinants of health, to the importance of reducing health inequalities, and actually talking about the impact that addressing things like somebody being in debt or being unemployed or being homeless, and the impact that that can have on their overall health and well-being. So it's really amazing that the community connectors have a voice in those discussions, and that actually talking about social determinants are as equally an important part of that patient's pathway and care as is their, you know, diagnosis and their medication and things like that. We use, like social prescribers, use a really person-centered way of working. So it's really, really important that we are finding out what letting the individuals tell us what matters to them, and that's what really drives the support that the community connectors provide. As I said, there isn't, in terms of a journey, we allow the community connectors, and what's great about transformation is that community connectors have a bit of freedom to be able to have the client determine what that journey is going to look like and how long they're on that journey for, as opposed to, say, for example, in our social prescribing service, we may say up to 6 sessions and, you know, you're discharged and that's it. The community connectors have the freedom to do that, which is wonderful, because what we find is at the point at which community connectors are engaging with clients, the journey is a lot more longer, because they are dealing with a lot more struggles. What we find is that people that have, you know, serious mental health issues, they are more likely to get themselves in a situation where they might be in debt, and it could be the anxiety and the struggle of not wanting to kind of deal with like sort of every day-to-day life stuff. And so the community connector is not only sort of dealing with the urgent crisis, but they're actually on a journey with that client to think about how can we actually improve your overall lifestyle so that you have more ownership and you're more empowered to be able to deal with those everyday things in life. So that one-to-one support is really, really important. But another element of the mental health transformation with ELFT is to look at reviewing just generally how mental health support is provided in the community. And an area that the community connectors work on is about how can we give a voice to often these groups of people that may be marginalised or don't have the skills or to advocate for themselves often. And so the community connectors developed a platform with participants to kind of co-produce a discussion, I'd say, or maybe like a peer support platform, which we call Let's Talk About Mental Health. And I'm only mentioning that now because recently Naomi and I and the community connectors, we had a bit of a focus group with that existing program to see, you know, is it working? Is the platform useful? And what would our clients on the community connector program like to see in mental health services? What would they like to see change? And a lot of the feedback that came from the group was around, you know, having a place to feel secure, you know, having the opportunities to have conversations around mental health without judgment, having a chance to share their own experiences, you know, places of honesty and transparency and non-judgment, you know, taking things at their own place. So there was this real strong emphasis on the environment and how they were feeling, which was really, really interesting. And, you know, a big part of it was connection. And I think that a lot of people said, Naomi maybe might want to chip in, but we kept hearing this thing about, you know, we want services where we can feel less alone and more connected. We can have people to talk to, and we can have trusting relationships, and we can sort of be around people. Isn't it perfect that, you know, the Community Connector project is then rooted within the community? I think for me, it's really important that we look at mental health from a community sort of level, because, you know, people are more likely to engage with, you know, the local community centre that they're already a part of. But if we can bring mental health support there to them, then it's more likely that we'll see sort of higher levels of engagement. And so I think I would definitely say more projects like the Community Connector programme, you know, regionally and nationally, because we've seen that it's provided a lot of support and help to the community.
Cool. Thank you, Layla.
Yes.
You were fantastic. You lived up to it. There's a few questions that have come through in the chat, so I'll put those to you. The first one is from Emily, and she asks, what do you think the key to empowering those individuals is? How do community connectors do that? And is it about co-production?
Yeah, thanks, Emily. Yeah, so I think the key to empowering people is putting their healthcare and their well-being in their hands and not in ours. I am not the expert of that person's life or their journey. I think it's about, from the very beginning, making sure that the challenges that are being identified are not being identified by me. Like, so I'm not saying, oh, this is your issue or problem and this is what we need to sort out. It's like, well, actually, what are you struggling with? What are some of your challenges, and working from there? And so it is really rooted in that person-centered way of working. I know I bang on about it a lot, but if something is being driven by myself as a professional, I believe we're less likely to see lasting change, as opposed to if it's coming from the individual themselves. We're more likely to see sustainability, ownership and empowerment if it's coming from the individual. And you know what it is? It's trusting that, you know what, you are the expert. I'm only here to facilitate that journey and be a part of it. And if you've got questions to ask me, that's great. But really, we're driven by you. And I think giving people that ownership and that empowerment, it gives them the confidence to be able to think, yeah, actually, I can do this. I can drive myself forward. And so that's what I would say. And co-production, again, Emily, is really, really important. Just the workshop that we had, I'll go back again a couple of weeks ago, it was so nice to see people giving their feedback, but also talking about what it is that they want in terms of, you know, mental health support and group sessions. And we really need to do that a lot more, and to kind of, a lot of the time in the group, the participants kept talking about power dynamics a lot, and they kept saying that, you know, we want a space where we don't want it to be professional and participant, and so it's really important that we value the skills that our participants can bring to the program as well, because we can also learn from that as practitioners.
Mm-hmm. Cool. I'll just move on to next question from Florence, and it's, how do you work with mental health practitioners within primary care networks?
within the program. Yeah, so what's really great about the programs, as I said, the community connectors are sitting within primary care. So we cover 2 primary care networks of about, I think total maybe 8 practices. What's really great is that the community connectors are able to attend sort of practice meetings and clinical meetings so they can speak to staff. At Bromley by Bow, the PCN is very much how can I say, we're quite well versed on social determinants of health and the importance of that. But I think that there's still a lot of work to be done in terms of speaking to clinicians about what the actual differences are between the community connector program and the social prescribing program. So I think with primary care, that's what it is, because with secondary care, the community connector program is new and it's new to them. But for the primary care, they're very used now, they're quite used to having that social prescribing role. So for us, it's working out and discussing what the differences are between the 2 roles.
Cool. Rob has asked if we can share a job description. I'm sure that'll be fine. And I can send that with emails after.
Yeah.
Yeah,
no problem.
Then there's a couple more questions in the chat. And Aileen, do you have your hand up this time, or is it more applause? There's a hand up. Cool. I'll just do the 2 in the chat and then we'll move on to Aileen and then we'll wrap it up. So Rob again, and it is, are the community connectors working within mental health or with all individuals? No,
specifically Rob, on people with SMI, so serious mental health illnesses. So that's mainly who they work with.
Cool. And Emily has asked, what is the training for community connectors? How do they become knowledgeable about the assets available?
Yeah, so in terms of the training that they receive, they would receive all the core trainings that our social prescribers receive. So that is, person-centered training that the centre developed, social prescribing training, things around mental health first aid, the assist suicide prevention training, motivational interviewing so that they can develop coaching techniques, and then things like trauma-informed care. And then there are specific bits of training that I believe the neighbourhood mental health teams can also deliver to them as well. But that's everything that we do sort of on our side.
Cool, brilliant. And Aileen, over to you.
Thank you. That was an amazing presentation, by the way. Well done. But I thought I'd kind of give a comment around how ELFT is working, because it's been an amazing partnership. So here's the thing. Because they're actually embedded within our neighborhood teams, our community connectors have an understanding of both sides of the story. And that really supports kind of navigating the pathways. And you say to us, what does that look like? Here is, this is backed up by data. See, we're all smiling. So here it is. We now have data of people who used to present in our crisis pathways all the time. And as soon as they started working specifically with our community connectors, guess what happened? We have a significantly lower number of these known individuals presenting to the crisis pathways. And actually, a significant number now access services within the local population that's not normally, or rather, biased towards mental ill health. And I'm being very clear about that, because the focus is about health. It's focusing on functionality, on strength, everything that kind of Jacqueline and Steve and Kelda has kind of talked about, and Naomi. And that is as much evidence really as a push for us to say, listen, this works, this alternative way works. And we're really trying to work hard in actually making sure that this is completely embedded in our culture right across all services, so that the understanding is not just about professional biases and clinical understanding, because the local population really has a lot more to offer. And it really does work. We have that data. Amazing work.
Brilliant. Yeah. Cool. I just wanted to open now. We'll wrap up in a minute because I know we've completely ruined everyone's lunchtime probably. But I just want to open up if anyone's got any questions to any of the speakers, just to either put them in the chat or feel free to unmute yourself as well and put those in. Sure, I can't see anyone with hands up. Cool. In that case, I just want to say thank you to everyone who came along today, and yeah, thank you for coming along, and thank you to all of our speakers as well, because you were all absolutely brilliant. Great to hear. And I just wanted to let you know, I think some of you might have been on some of these. I mean, there's probably a few social prescribers amongst our audience today. So this is the last in a series of webinars we produced in, not today's webinar, but on the 17th of March. Last of a series of webinars that we produced with both the GLA and Healthy London Partnership, who are now called Transformation Partners. So that'll be on the 17th of March, which is a Friday at 12:30, 2 o'clock. So I'll send out the link for a sign up to that as well. And no problem. And I can see a few things coming in on the chat. Yeah, to Sarah, yeah, we'll send you the slides as well. Yeah, that's no problem when we send this out. So there's a question from Florence. I don't know if this will sort of for everyone, but she's asking if she can work with someone who can provide a case study for our guided document that we're working on. So it's a London primary care mental health. Florence, if you're there, yeah, go for it.
Would you like me to say something?
Yeah, that would be brilliant.
My name is Florence Cantle. I'm actually a program manager for London NHS and England not mental health, although I'm a mental health nurse by background. So primary care team. So I'm actually chairing a task and finish group on behalf of London IAP, mental health, primary care, mental health integration, primary care, secondary care steering group. It's just really part of the work that we would like to produce at the end of the day. This guided document that we're trying to work on is really to broaden, the roles in mental health between primary care and secondary care, particularly, for the primary care networks, the R's roles, the mental health practitioners. We really want to ensure that, with the community connectors role, and also, already been worked on, the community mental health foundation program. We really need to disseminate all these good exemplar practice to the world, you can say, and spread out to London region, all the ICBs, you can say. So I really would like to welcome a case study, perhaps offline, to talk you through. And thank you for your time. Thank you. Very well done, by the way.
Yeah, thank you, Florence. Let's have a look at the chat. Yeah. Cool. I think you've sent that to me, Aileen. I'll send that on to Florence. Cool. No problem. On that note, if there's no more